a lot of those communities that are disproportionately impacted need to be thinking about this and engaging in these conversations a lot sooner. I'm not going to take a lot of time, but I do want to highlight, if I can move it forward. Okay. You saw this earlier from Tricia's presentation in her slides, but when you look at what income looks like, a median per capita income by race and ethnicity, and as you can see, there are huge gaps, particularly for African Americans and for Hispanics. And you've heard earlier some of the reasons for that in terms of who's in the workforce, higher unemployment rates among people of color, as well as lower wage income jobs that they have, leading to some of these incomes in retirement for our seniors. And Tricia also mentioned the savings that we see, and this is just, incredible and stark when you look at the challenges of where people are looking in their reserves. And again, one of the things to think about is, some of the survey results that have been looking at who the uninsured are and how you can have savings. When they've paid their bills, more than half of the uninsured have less than $100 a month left over. So as we think about how do you start to put away money when you're struggling to pay your day-to-day bills, particularly when you're younger and thinking that's so far down the line. How do we start making people even just think about $5, $10, where they can make a little bit and make a priority for saving so that these numbers look a lot larger as they get to retirement and into Medicare. And as you think about as well, you see the bottom line where we see that it's not even that everybody has these savings, that there are proportions of the populations who even have any savings differs pretty significantly as well. So it's continuing the doom and gloom, I guess, a little bit. But as we think about health outcomes and what this means, many of our communities of color are coming into retirement sicker and needing and relying higher rates of chronic conditions, using more prescription drugs, and spending more on health to begin with. So as they come in a little bit sicker, less resources to help take care. And when we think about retirement security, it's not just about income. It's also about that independence and being able to stay at home. And one of the things is we think about spousal support. And when we look at marriage rates for those who are 65 and over, nationally about 58% of individuals who are 65 or older have a spouse who's actually present. But that number is nice and depressing for African Americans, where it's only 37%, and a higher percentage have never been married. And you think about not only what that spousal support means of income, but also social support of someone who can help get a meal, drive you to medical care if you need it, and be there to add another support is a challenge that is disproportionately among African Americans, less so for Hispanics and less so for Asian Americans. But thinking about retirement security, it means much more than just finances. And when we think about that, I think my 91-year-old grandmother who lives about 6 miles from here, she pays, for public transportation, which gets me into some of the, other pieces of the importance of our social programs for older Americans, food programs, transportation programs, and other even just visitation to make sure that someone is checking in on our seniors to see that they have what they need to be able to stay home and be independent. And as you look at those out-of-pocket expenditures, even the transportation that my grandmother takes, it's $3.50 one way, but that's every time she needs to go to the doctor or anything else. And if we can't take her, then she's paying that, and it gets to be a lot on a very limited income with very few savings as we move forward. So when we talk about social programs and we look at what Medicare's role is, and we've already heard the importance of Medicaid, but Medicaid is particularly important for our communities of color. Because of the income inequalities, many of them are dually eligible. They benefit from things in Medicare like the low-income subsidy to help make sure that they can pay for prescription drug coverage, but also relying on a number of those other programs, housing subsidies, supplemental nutrition assistance programs. And so as we're looking at what the future means, it's really important that we also talk about these programs and how we can continue to support them, and the importance of where you live and how that matters. Our seniors are distributed across the country in very different ways by race and ethnicity. When you think about our older Asian Americans, more than half of them are on the West Coast, where some of the programs, you think about California and a lot of the social support programs that are there, social determinants, they're a little bit further ahead than maybe parts of the South, where we have more than half of our African Americans who are living in those states and thinking about Medicaid expansion, other generosity of some of the social programs. These are very challenging times for some of our populations, and where you live matters. So finally, when we look to the future, thinking about what the horizon looks like. So currently among our older Americans, it's a less diverse population than those who are under 65. And as we already know, by about 2050, more than half of the U.S. population is going to identify as a racial or ethnic minority, with Hispanics being one of the largest populations. And as you can see, as we look at those who are non-elderly in their household, the proportion of the individuals who are living in poverty is significantly higher. And what that means, again, going back to that, having resources left over after you've paid your bills to save, they're coming into a system and needing a lot more, and that continues to be a challenge as we move forward. So what can we do? I think we've heard earlier already about financial literacy. One of the things that we have done with regards to helping the newly insured who are coming in to understand and improve their insurance literacy is a program called From Coverage to Care. It talks about how we can help people understand how to use their coverage and connect to health care, particularly primary care and preventive services, so that we can try and bring in a population into retirement that's a little bit healthier. But it also is talking about maintaining some of those social programs and ensuring that their wraparound supports are there, particularly for our low-income communities and particularly some of the communities of color that we have. We also need to think about our diversity and how it is changing. We see a growing number of individuals who speak a language other than English at home. And when we think about a lot of our older Americans, we don't really think about translating resources or making sure that there's an interpreter there so that individuals can navigate the healthcare system and get the services that they need. But as we become more and more diverse, we have over 25 million individuals in this country who speak a language other than English and speak English less than very well. And that's going to continue to grow, and those languages are also growing. So as we move forward, I think we need to think about how we can help support people who are struggling day to day to begin to create savings so that they have that security in retirement. But I look forward to more conversation. Thank you.
Okay, and Rosemary Gibson.
Thank you. Thank you, Tricia. Is this on?
No.
There we go. How's that? Good afternoon, everybody. I'm Rosemary Gibson. I'm a senior advisor at the Hastings Center in Garrison, New York. We are a healthcare ethics think tank. I'm also an editor for JAMA Internal Medicine. That's a medical journal. And we have a series called Less is More. And we publish evidence of overuse in medicine. And I started a narrative series of patient and clinician experiences of overuse. And in my spare time, I wrote a book called Medicare Meltdown, and I think that's why I'm here. I want to thank Ellen and Max Richtman for the opportunity to be here this afternoon. I have 3 stories, and out of them come some maybe little policy ideas.
Great.
So the first story is a gentleman I met while writing Medicare Meltdown. He had written a letter to the editor in his local newspaper in Kentucky, rural Kentucky. And he described how he went into the hospital for one night. He had a procedure which he didn't name and I didn't ask because that's private. But I suspect it may have been the insertion of a pacemaker or defibrillator. Is that possible, Valerie? Mm-hmm. So one night in the hospital, and he got a bill for that one night in the hospital that was $244,000, which is about the price of a house, even more so in his community in rural Kentucky. Fortunately, he was on Medicare, and he had supplemental coverage. And he didn't end up paying a whole lot of money. And Medicare, fortunately, negotiates how much it's going to pay and sets how much it's going to pay hospitals. So the cost that all the insurers pay, which is still a lot of money, $19,000, is a lot less than he would have had to pay if he didn't have insurance or if Medicare did not negotiate or set prices. Now, we've all heard about the price of drugs going through the roof. So there's been conversation about, well, why don't we negotiate prices for drugs? And often we hear that, well, there's research costs, and that's true. But what if? What if there was price negotiation for generic drugs, which account for about 85% of the drugs that Americans take? There's no research cost there. And most of them are commodities. I'm working on a new book, and a lot of our medicines now, most of the active ingredients in our drugs are made in China. And now we're getting Aricept made in China, the drug for Alzheimer's, drugs for Parkinson's, blood pressure medicine. So why can't we negotiate the price, at least of generic drugs? Have you seen the price of doxycycline, a common antibiotic that's been around for years? You used to be able to get it for $20. It went up 900% to $1,800 for a common antibiotic. And the advantage for retirement security is, when your drug prices just shoot up, this is for anybody at all ages, it really causes a sense of insecurity. So why can't we build some security in about the price of drugs, whether the premiums as they reflect in Medicare Advantage plans or Part D plans or out-of-pocket? We still have some work to do to make those prices more affordable and more predictable and lower cost. So here's another story. This is about my 90-year-old Aunt Muriel. Aunt Muriel lived in Maryland here for many years, and then she moved over to assisted living over in Virginia. And she had been taking a medication for a number of years that's meant to help with osteoporosis. But one of the known complications of this drug is that it can cause some deterioration in the jaw bone. And apparently she wasn't being watched by a primary care physician or geriatrician. We don't have enough geriatricians. The number of physicians who specialize in geriatrics is actually going down at a time when we have the most people in our sites who are getting older. That's something else we need to fix. Every older adult should have a primary care physician who has good experience and training in the care of older adults. Anyway, so my aunt ended up having surgery, a dental procedure, to remove a number of her teeth. She had a beautiful smile. Smile's gone now. And then she ended up having a reaction to the anesthesia that required her 6 weeks in a rehab facility. And then she needed help. It's heartbreaking. She needed help when she went back home to her assisted living facility 24 hours. I've spent some time working on patient safety and medication use. Boy, we got to get a handle on appropriate use of medications. So here's an idea. We have Medicare value-based purchasing. And Medicare's value-based purchasing now is incenting healthcare providers for safer, better care. So I just came back from a trip. I was in Dallas the other day, and there was a hospital that I was visiting, giving a talk, and they've had no central line infections acquired in their hospital for 2 years. And what enabled that to happen was that Medicare, as part of value-based purchasing, said, we're going to ding you for these preventable infections. We can have better care at lower cost. So why don't we bring some value-based purchasing approach when it comes to medication use to incorporate that? Finally, a third idea and a third story. I was talking with my sister the other day, and I don't wear glasses, but she does, and she was telling me how much eyeglasses cost, and they're not cheap, right? And a colleague of mine went to have cataract surgery, and thousands of dollars, and some of that's for the lenses. So why is healthcare so expensive? Do we ever see the price of things in healthcare go down? Why are they always going up? quick factoid, when Medicare was established, there was not a single healthcare company on the Fortune 100 list. Now there are 15. So they have to keep growing and growing and growing and growing to meet shareholders' expectations for return. Good news, there are some capitalists out there that have a different approach. You might have read NPR's story about David Green, who's coming out with hearing aids that don't cost thousands of dollars, but high-quality hearing aids can be bought for $100. Eyeglasses. That, a lot of people around the world wear eyeglasses and they're fine, but they can't afford them at the price that we charge here. Why not have disruptive technology and bring that into our supply chain in Medicare to make these things that make day-to-day life, our ability to see, our ability to hear, affordable for everybody and affordable for Medicare for generations to come. We've got to do this. Final factoid, when I'm older, in my 80s and 90s, we'll have a whole lot more people on Medicare. How many more people? It's equivalent to the combined populations of Austria, Hong Kong, Israel, and Switzerland. Imagine all those people from those countries now will be coming on Medicare in terms of numbers. That's why we have to do what we can do to make retirement security reality for all Americans. We deserve it. Thank you very much.
I'm just thinking of the ethnicity. So we have heard a lot of ideas, not just depressing thoughts, but also some interesting ideas about how to move forward. And we have about 15 minutes before the next panel, which will also be great, which is going to be talking about for sort of media issues. So I am hoping that there are questions in the audience, because I'm sure if you don't have questions, I have many I could toss out, and I do see a few. I think the microphones are coming.
Hi, I was so glad you mentioned the hearing aid problem, because the National Committee took some of us to a briefing. And what we discovered is not only the cost of the products, but the fact that it can lead to dementia. And because the brain gets restructured. And I wonder if we should not, I don't know how successful this person is, but the doctor who was working on statistics there, his name was Frank Lin, L-I-N. He's working with Johns Hopkins. I'd like to know more about that, because as you get older, only sometimes just small sounds disappear. You're not really hard of hearing, because I went for a test after that. And they, of course, wanted to sell me hearing aids. I don't need hearing aids. But it would be nice if you could let some of us know about what you've discovered.
Sure, just briefly. When I was at the Johnson Foundation, we funded this group called Ashoka that worked with David Green, who was finding a way for people in other countries where they don't have a lot of money, but they get cataracts just like us. A lot of them can't afford sunglasses. They're in tropical countries, and their eyes are adversely affected. You could buy really high-quality lenses used in cataract surgery for a few dollars. And, we think of that, oh, my God, cheap is bad. I think we have to start looking and incenting high-quality, disruptive technology so we can make it affordable for everybody. There's no reason we should be spending thousands and thousands and thousands of dollars and get the market to work. His name is David Green, Google NPR, and I think we need to add this to our dialogue on how do we ensure, if there's a push on hearing aids, to make it affordable and high-quality products for everybody that needs one.
I think before you go to the next question.
And I just wanted to add, from the smart purchasing of healthcare services side of this, is that we should be spending, I believe, our money in this country on things that help prevent much more serious things. And so not being able to hear well is a safety issue if there's a fire or other things like that. And as you point out, as people lose their hearing, they kind of start to get shut in, and it certainly contributes to lack of social engagement with their family, with their peers, and all of those things can accelerate any deterioration that may already be underway. So many people have heard me talk, I've heard me say this a million times, we have a sick care system in this country. We don't really have a health care system. We're trying to turn the ship to be more of a health care system and put money into prevention and keeping people healthy in the first place. And this is a great example of a step that we need to take to help us get there.
I mean, this is actually an extraordinary situation because this is a situation where Medicare does not pay for it. So there's a tremendous demand, and people can't afford to purchase hearing aids. Many people can't afford to purchase hearing aids, and yet the market is not stepping up fast enough to deliver a lower-cost product that people can afford. So in some ways, it's the ultimate test. It's an ultimate reason to say, yeah, it's not necessarily a bad thing to give people coverage, because even without it, the market's not responding, and people can't afford it, and then we have all these clinical adverse outcomes that are a real issue.
But I think it'd be very fascinating to how can we bring good people who want to make this market work for America's seniors.
Catherine Dodd, National Committee, and I actually wanted to echo the comment about seniors becoming more insular. Based on research at UCSF on dementia and on depression, the National Committee sponsored legislation to add hearing aid coverage to Medicare. Obviously, it hasn't gone anywhere, but I think it's one of those things we have to continue to push on. And in the interest of mental health parity, if we can prevent depression in the elderly, it will prevent people from being put on pills that will make them fall, et cetera, et cetera. It's a long curve. And then I wanted to ask, what about the PACE, Judy, what about the PACE programs? PACE has been around for 30 years, for a long time. It's proven to be successful. Why doesn't it get expanded?
Well, as you heard the Congressman describe the PACE program, the Program for All-Inclusive Care for the Elderly, it combines Medicare and Medicaid resources for people who are nursing home eligible and treats them in the community, usually at daycare centers, but they're able to live at home. The program is enormously successful, but is, as I understand it, is resource intensive, and more entities can qualify. The opportunity is there. Providers who come together and create those kinds of service organizations can qualify for Medicare, but it is a challenging program. It seems to be a challenging program to put together on the ground, and I think its evaluations show it to be a very valuable program in terms of providing people quality care, but it is not an inexpensive program. And the focus today, unfortunately, in terms of what's being pushed in policy, are programs that will be forced to save money. So alternatively, the administration has promoted in Medicare demonstrations covering dual eligibles, Medicare, Medicaid beneficiaries, for fixed sums of money, not different pays, but those have been largely, in the states that have tried them, have been managed care companies who don't know how to serve this population. They never have done it before, and who are expected to take a sum smaller, less than what is otherwise being paid. Now, they exist. They're larger, in my view, than they perhaps ought to be, because I think there are real questions about their quality. But what we need to recognize in terms of improving services that go across health and long-term services and support, that this is not likely to save money. It may reduce unnecessary hospitalizations, but you have to invest in the personal care services in order to achieve the results, the better care that can prevent unnecessary service use. So they are not about saving money, and unfortunately saving money is very much in vogue.
In the back?
Hi, Lance Kilpatrick with Caring Across Generations. I wanted to ask the panel, and Judy, I'm actually going to follow up on what you were just saying about saving money. It's been proven by many different studies, most recently my friends at ARP, regarding the costs of being able to stay in home, where roughly 90% of us want to be able to age in community, versus going in a nursing home. I think that the latest figures are something like $30,000 for home care versus $80,000 versus a year in nursing home care. Why aren't states drastically biasing towards home and community services versus the structure that we tend to have today? And when I say drastically biased, I know we're trending, but come on, if it's all about saving dollars and providing better outcomes, why aren't we radically going after this?
Well, you want to?
And it's for everybody, but you spoke last
It's really
time,
for
so.
Judy.
The comparison you make between the $30,000 at home and the $80,000 in a nursing home is a per capita, a per person comparison. And what we know about people who need long-term care is that they don't want to go into nursing homes. They want to stay home. So a lot of people who need care are not in nursing homes. They are at home, as I said, depending on their family. So when we look at the costs of expanding services at home, we have to look beyond the per person cost to the total costs. And the reality, and indeed the intent of expanding home care, would be to reach many more people. And consequently, when you reach more people, even if it's a smaller dollar amount per person, you end up potentially spending more or spending the same money. That's really, I think, what we should expect, not saving a lot, but spending more money more wisely in the way people would like. So they're not nuts at the state level when they're looking at budgets. They're just only looking at budgets is what it amounts to. The other thing I would caution us to think about is that as we move, and we are moving slower for older populations than for younger people with disabilities, but we are, as we encourage home care, that desire to spend less can mean that although it sounds good, we're supporting more people at home, if when we have them at home, we don't give them enough services or fund them to get enough care, then although they got to stay at home, they are not getting what they ought to get.
Question? Okay, one more I'm going to take the last question. I've heard a lot of discussion on the panel about ways to improve Medicare, but there's kind of a disconnect between what I'm hearing on the panel and what I hear in other settings. I was speaking on another panel, and one of my fellow panelists said there's broad agreement to move forward with premium support for Medicare. There's also interest in raising the age of eligibility. Nothing, by the way, anybody on this panel's talked about yet. There's interest in giving people on Medicare more skin in the game, having them take on more personal responsibility. And I see some people in the room grimacing, but in other settings, these are sort of commonly described proposals. Means testing, introducing means testing even more into Medicare. So anybody on the panel who doesn't want to duck want to comment on what I'm seeing as a real divergence in views about the future of Medicare?
I'll take a stab. I think there's a narrative out there that's been crafted, and it goes something like this. Medicare costs keep going up, so either we've got to raise premiums and cost sharing, have seniors have more skin in the game. But nobody is saying, well, maybe we need to broaden those who really need the skin in the game. And that is those who are supplying health care. I tested this phrase with an audience up in Maine about a year and a half ago, and it goes something like this. Seniors' entitlement to Medicare is not the reason that it's heading toward a fiscal cliff. The healthcare industry's sense of entitlement to Medicare's money is the problem. And that was a mixed audience of hospital folks and others. And I think we have to have the courage to go change the narrative. I talked to a hospital CEO who, they're a Baldrige winner. They're really trying to make care better. And I said, how inefficient is all this money being spent? He says, I could have better outcomes for my folks on Medicare. He's not just a cut. He's a physician who really believes in doing the right things. I could have better outcomes for people on Medicare at half the cost. All the waste that I see of what we do, and if it's not half, let's make it even 90. We could save so much money. But the industry has to have skin in the game, and how it prices and what it does. And I think we're going to have to go there if we want to make Medicare sustainable for Americans for generations to come.
Anybody else want to add to that?
Hear, hear.
It's a tough conversation to have, but I think we need to have it. It's not very politically correct. But I think we ought to turn the tables when people say seniors need more skin in the game, and turn it exactly around and say, what skin in the game do all the industry players who make money off of Medicare, what's their skin in the game?
So I'm going to, Judy wants to say one last thing.
One quick thing. First of all, here, Rosemary, it is about paying providers less, not about covering people less. But I would also want us all to recognize that with the aging of the baby boom population, there are many more of us. And as we do a fine job of getting the providers to have skin in the game and getting medical care cheaper, we are going to need some new revenues. And this is a group that should not shy away from recognizing that we are all in this together, and as a community, we need to support each other.
We have the evidence at JAMA Internal Medicine, some of it, little pieces of it.
All right, on that public service announcement, I'm going to say I see a colleague of mine who is going to be on the next panel, so we're going to move forward, Mary Agnes Carey. So we're going to say thank you very much. Join me in thanking our panelists who are terrific.
It's a pleasure to listen to you. Thank you.
And thank you for being a great audience.